actually it's a term that encompasses all the different lining structures within the tendon. Okay? It's a loose areolar tissue, and it's a sheath. And the purpose of the sheath is to protect the tendon from sort of micro or macro trauma. It glides because it also is responsible for producing a synovial fluid, and also the tenon itself is a source of remodeling, healing potential, or the inflammatory response needed, okay, to heal. The epitenon is a layer below that thick paratenon you see when you do it. So when would you see it? Who's done a something like a
knee replacement?
Yeah, the knee replacement. Yeah, you know, the knee surgeons go on about repairing that at the end, right? It's really important.
In Achilles tendon?
What's that?
In Achilles tendon, probably.
Yeah. But the one example I can think of where you can see a definitive paratenon and epitenon is it. You know when you do a flexor sheath infection, where you put your hand up.
No, I was just saying in the hand.
Oh yeah. You know when you do a A1 pulley release or you do a flexor sheath flush out, there's a really thickened paratenon next to the pulley, and you can actually, you can actually see it. Or if you've ever done a tendon harvesting of the FCR in the forearm, it's a really good example of a paratenon with epitenon. If you don't get your suture or tendon passer into the tunnel and you strip into the paratenon tunnel, then you strip it, it's a disaster, right? It's an absolute disaster. Anyway, endotenon is the layer at one hierarchical level below the tendon that surrounds the fascicles. Okay. So this is fundamentally the picture I was asking you to draw. Okay, so it looks exactly like yours, right? So you start right at the bottom with the tropocollagen and the collagen and the fibril and the tenocyte, the squash tenocyte in between each other. Looks like yours as well.
I'm telling you, it's not a million miles away. I can't label that.
And then all the fibres form a fascicle, and then you've got lots of fascicles forming a tendon, or a bundle of fascicles forming a tendon. The endotenon over a fascicle, epitenon surrounding the whole, all the bundles, and then the paratenon, the tendon whole. Another drawing, and for bonus marks in the exam, the scale as well. Okay, this is where you get your 7s and 8s idea of the draw. Those figures at the bottom, right? Okay, moving on to another sitter of a question in the exam, right? How does a tendon insert into bone? Okay, and I just want to bring ligaments into this. Come in. So this would be good teaching for wrists, because wrists is all about bone, right?
You never noticed about tendon.
Yeah. Tendon is something you sort that down a lot. Right?
No trouble.
Okay, so if we just put tendons and ligaments into one bundle at the moment, how do they insert into bone? Well, there's an indirect and a direct. Okay, principal method by which a tendon inserts into bone is indirect, and the principal method, a ligament attached to bone, is the direct. Okay, however, there is crossover. All right, the indirect method is with 4 distinct zones. Okay, and there's going to be another drawing in the next slide. You're going to need to be able to draw in the exam. Zone 1 is pretty much, okay, all the collagen fibres have come, have spread out from a delta type thing to form a nice long tendon from the muscular tendon junction. The collagen fibres are nice and straight, they're parallel, and they're pointing towards the insertion. Okay. Zone 2 when in between all the collagen fibres, you're beginning to see kind of finger-like projections of the fibrocartilage invading in between the nice, strict, regimental, military parallel lines of the collagen. Okay. Missed the zone. Zone 3. I think. Yeah, zone 3 is when that unmineralized fibrocartilage begins to get replaced by a bit of mineralization, calcium, for want of a better word. So there's a transition from soft tissue, jelly-like, intermesh-all fibrocartilage, followed by the cartilage becoming a bit calcified. And then finally, that fibrocartilage, calcified, mineralized fibrocartilage, merges into the cortical structure. So it's a clear and distinct, slow transition. Whereas a direct or ligamentous insertion is almost ligament, then bone. And the only thing attaching the two is the periosteum, an invasion of the Sharpie's fibres from the periosteum into the tendon. It's a really short transition zone, but it's normally very broad. So ligament insertion is normally quite broad, whereas tendon insertion, because it has a longer transition zone, is able to narrow its focus of insertion. All right? However, when I ask a tendon to repair itself onto bone again, doing a reconstruction, I'm often asking it to heal via a direct method, rather than if it should be a indirect. So I do that by doing lots of drill holes in the bone down to the cancellous portion, and make sure my tendon graft is anchored or sits onto that cancellous raw bone, so that when that bone heals, you get Sharpie fibre invasion into my graft. Okay? So you can trick a tendon into healing by direct healing to bone, by making sure it's bedded onto a cancellous portion. And here's your picture. So zone 1, on the left, nice strict regimental. Zone 2, the fibrocartilage and the chondrocytes invading, disrupting the soldiers a bit, right? And then zone 3, beginning to get speckles of mineralization. And then zone 4 is invasion into the cortex. Okay. Yeah, so another classic picture. That's a shame. I had actually put this on animation. Because this was the next quiz. You missed lots of quizzes, guys. Okay, so this is our bread and butter. Basic science is bread and butter. This is a stress strain curve, right? Okay, so you should be able to, be able to draw the axis and describe the axis of a stress strain curve in 20 seconds if someone asked you to do a stress strain curve. Right? So strain on the x-axis, it has no units. It's a ratio. Strain is the changing length over original length. Okay, so it's a ratio. So it has no units. With stress, in most biological materials, it's mega or kilopascals. Okay, but for a tendon, it's megapascals. And this is your pretty typical biological stress strain curve. Okay, in a tendon, you've got a toe-in region. Anyone know what is represented by the toe-in region or toe region?
It's the recruitment of all the fibrils, right?
Yeah.
It's the line.
Absolutely. So you imagine an elastic band. It's just a little bit loose, just lying there. Okay, and you just pull it straight. Okay, you just slowly pull it straight. Now, during that portion, doing that pulling it straight, very little stress is being transmitted down this length, almost zero, until you get to the point where all the elastic fibers of the elastic band are straight. Okay, so this is where all the crinkles and wrinkles of your tendon are just being pulled straight. Okay. Then there's the linear region where its behaviour is pretty predictable. Okay, for every centimetre of the strain, there's going to be 10 extra pascals. For, you know, and it's, you know, so 2 centimetres, 20 megapascals. So 3 centimetres. It's pretty predictable, okay? And the tendon will behave in a predictable way each time until we get to P linear, and that's the maximum strength of the tendon before you start getting what traditionally you'd get plastic deformation or failure. The tendon doesn't really plastically deform much before what happens? What letter?
D.
E. Okay? Yeah, I am confused. Okay? So there's very little plastic deformation in ligaments and tendons. You have this linear portion, then all of a sudden it quickly goes, I can't take any more, Captain. Okay? Really bad Scottish accent. Don't record it. Okay? And you get segmental failure. Can you see that sawtooth drop? Okay? So that's where a fibril or a microfibril or a fascicle fails. They don't fail all at once. You know, even when you have complete rupture of a tendon or ligament, when you do an operation to repair it, you don't see, unless it's a laceration, you don't see just a clean break, do you? You know, example is the patella tendon or quadriceps tendon. You just see the stringy little octopus coming out through the wound when you open it up. All right, it's not a clean break. So you get this segmental failure until you get D, which is P max or UTS. UTS.
Ultimate tensile strength. The ultimate tensile strength.
Exactly, and that's where every single fascicle, fibril, fibre, collagen molecule has gone. They've all individually said, I can't take any more, Captain, and then just failed. Okay. So yeah, you need to be able to draw that pretty quickly and succinctly. Function. So this is the other really important function of tendons. I've already told you how it behaves linearly, right? Okay, really nice curve, but that's not the full story. What happens when you load it at different speeds or you let go of it? Okay, the tendon will not behave in a linear fashion, and that group of behaviours we call viscoelastic behaviour. Okay, so it's not just you don't just let go and it just comes straight back again. Okay, so the way I would just describe this by Nigel Rossiter was if you put a bit of plasticine on the floor. Okay, when Nigel comes to work on a Monday to Friday and walks on that plasticine in his normal shoes, he doesn't go anywhere, he doesn't sink, does he? Okay? Equally, if he comes into work on a Sunday and he walks very slowly with his high heels on, which he wears on Sundays, then he'll sink. But if he walks quickly on it, he won't. The behaviour of that material changes according to how you walk on it and what you walk with. So it has time and rate-dependent behaviour. And there's three kind of buzzwords that you need to be able to describe viscoelastic behaviour. Hysteresis, stress relaxation, and creep. So hysteresis is when you pull your elastic band, you get that nice linear curve, then you let go. It doesn't. When you let go, the stress doesn't go down the same curve. It probably dips below and then comes back to its original point. So the two curves are different. And bearing in mind the energy underneath those curves represent the total energy required to be able to deform something. Yeah. There's a difference between two curves. So therefore, say the energy is 10 for your loading, energy is 9 for your unloading, there's a difference of 1. what happens to that one? Energy loss. How is that borne out in real life?
Heat.
Heat, yeah. So when you go running and you touch your tendons, they're going to be quite hot, right? Because they're constantly loading and unloading, and you get loss of energy, which normally releases heat. Stress relaxation describes a situation where if you load something and hold it at a constant strain or constant length, okay, for simpletons, but technically it's strain. If you hold it at that strain, so the changing length, then the amount of stress needed to keep it in that position will decrease the longer you hold it. Equally, if you hold something under a constant load, the amount of deformation with time will increase even if that load stays the same. So, Prim, when you do a ACL reconstruction, are you guys still doing
Cycling now.
cycling?
Not anymore.
Not anymore.
So the evidence for that's gone.
Yeah,
We used to do that to take the stretch out of the
exactly. Yeah.
graph, and get it, but the advice now is that it's not worth doing, so we've stopped.
Is that because there was no?
There was no proven difference when you put
Yeah.
the KT 1000 or whatever on and stress tested it. The way, in fact, the surgical technique now in terms of how rigid the fixation is has slightly changed, and that kind of outweighs any stretch that you get. Having said that, the majority of hamstring grafts still seem to stretch
With time.
3 to 4 years down the line, but you can't reproduce that stretch acutely by cycling.
Yeah, in 2 minutes or
We're using those plastics to close the wounds. You hook the skin, keep it together, and then it's easier to close the skin.
yeah.
Less tension. So it's exactly the stretch structure.
It's not described in any of the literature, but after doing a knee job, when I do my scapholunate ligament reconstructions with my FCR graft through my scaphoid, I give it a few tugs, because Claire, I don't know how many Brunellis you've done, or do you do Brunellis anymore? No. So I find with time, probably just like your ACL, my lunate just slowly slips around because it just stretches out. Yeah. So all these things the knee guys no longer do it, but when I was a trainee, this is what your job as a registrar was to do the loading and stuff, and that was to combat some of the viscoelastic behaviours. Okay, so injury. Two principal mechanisms of injury to a tendon. 3 if you count a stab. Right? Okay, but we're going to talk about that's just a laceration. Type 1 is repetitive microtrauma, or type 2 is macro. So micro and macro. The micro trauma is fatigue failure. Okay, so that's the point where it's a bit like you've had segmental failure, like in our stress strain curve, of parts of the tendon in the smallest parts within the collagen molecules or the microfibrils, but the whole functionality of the tendon still exists. But because you have small little failures, you get inflammation. And with the inflammation, fibroblasts are stimulated to produce more collagen, and because that micro trauma, the environment causing micro trauma still exists, you have this constant want to cause localized inflammation and collagen formation without remodeling, so disorganization. So you end up with this chronically injured, disorganized collagen mess. This is characteristic of sports injuries, or people who haven't properly rested their injuries. An example of this could be like a hamstring injury, where they haven't rehabilitated properly. Now back playing football again, they get another injury, and they might rest it for a couple of weeks, and then they're going back again. They don't actually rest it properly. Macro trauma is when there's been an acute failure. So you have carried too many books from the library. You know, something that Nelson came to me all day. Oh, I'm doing so much work in the library. And that's where there has been total failure. So we have gone over the top of the stress strain curve. So UTS has been reached and gone past. Okay, and that's total fascicle failure. The location of that injury is dependent on how you've injured it. So broadly speaking, but never say never, if you're loading a tendon with low rates, then the bone insertion tends to be the weakest. Okay? If it's high rate of loading, then it's tendon that often doesn't have time to adapt or get through its stress strain curve before it fails. So it's funny, I was writing this last night, and I was thinking, hang on a minute, that's not strictly true, is it? Because I'm doing a skier's thumb later this week, all right, where patients fall over. It's a high rate of loading because it's a big trauma, and it's a bony avulsion, where, so there's stellar lesion, right? And there's a bony stellar lesion. Anyway, so never say never, but principally, this is where tendon fails. So taking the history is important. How did you fail? Because if it's low rate, the X-ray is probably not going to show anything, right? But if it's a high rate, then you might well see that bony avulsion from the corner of the bone. There's some controversy. I've already said that it doesn't always strictly stick to that pattern, because age and endocrine definitely have an impact on how and where tendon fails. Okay, so after the age of 20, sorry, your tendons are beginning to fail already. All right, it's all downhill. You remember the human body's only built to last 38, 40 years. All right, and it's only through evolution that we've not been able to keep up with that. Okay, and endocrine. So different parts of your life, different medical conditions will have an impact on your how your tendon fails. Okay, this is the last basic science slide, and I'm going to, what's the time? Quickly go into some sort of clinical correlates on how to tendon injury and how to deal with them, and how to be non-controversial in your exam. Okay. So tendon healing. So you remember you've got the tendon sheaths, okay, and you've got the synovial fluid within. There's not much blood supply, is there? Okay. So they're relatively avascular biological tissues, and they rely heavily on diffuse oxygen tension through the synovial fluid, or from neovascularization from the injury. Get rid of those two, and it's index. Okay, so it's not going to heal. So smoking, okay, and accurate repair, if you're going to repair it, is really important to make sure you get not smoking, stop smoking, and an accurate repair is really important if you want to give the tendon the best chance of healing. Phase 1 is pretty standard kind of this sequence of healing. Hemorrhagic inflammation occurs in hours or days, and it involves the recruitment of monocytes to gobble up all the debris, trim all the edges before the fibroblasts come along and start laying down some immature collagen. Okay, which is principally type 3. Phase 2, you get the neovascularization, and the fibroblasts get switched on properly. So you turn the oven up now, and now type 3 collagen is being laid down maximally. And that happens quickly, 1 to 3 weeks. And then phase 3 is a remodeling, and that starts at week 2, 3, 4, but goes on for years. It goes on for years and years. You can go back into a wound a year later, and you still see some scar tissue within the tendon. And remember, tendon healing, well, I think I'm going, is at weakest and it's day 14, and then you begin to get strength again by 21 days, and that's the point where you, 21 to 28 days, and that's the point you get the hand therapist to get them going. So you get early orientation and reorganisation of the matrix. Another classic picture you need to know, but it's important to know the location of these vinculi. So within this part of the finger, you've got a sheath, but you've got no blood supply within the sheath. So it's diffusion of the synovial fluid which is feeding this, or it's the vinculi, short and long vinculi, providing local blood supply. So depending on where the injury is, depending on whether you can leave it to repair it later or repair it quickly. I think leather and Packer's classification. Oh, here we go. Blood supply within the sheath, diffusion of synovial fluid, proximal to the MCP joint, low oxygen tension, or outside the sheath, there's a direct vascular supply through the vinculi. Okay, so there we go. Another picture. I've put lots of pictures you need to learn to draw. And remember, Nelson, which pulleys can you sacrifice, which ones can't?
You live 2 and 4.
You can
Leave 2 and 4.
Yeah.
You can sacrifice 2 and 4.
you can sacrifice the odd, keep the even. Yeah. So the way I remember this is, what's the treatment for trigger release? A1 release, right?
Yeah.
Okay. So just remember, you can sacrifice A1 because you release. You release it during a trigger release. So that's an even you have to keep. And this is why. Okay. So imagine you've got a rupture of A3, and then you've also got a rupture of A2, or you've sacrificed 2. You can see huge bowstring. And the point there is that you lose your lever arm. So not only do you get bowstringing, but also lose the lever arm to counteract the extensor forces, or balance out the extensor forces. So you end up with a imbalance and flexion position and a bowstring. The zones you need to know, as is really, zone 1 up to the middle phalanx, zone 2 up to A1 pulley, zone 3 the palm, 4 carpal tunnel, 5 forearm, and then 1 the thumb, slightly different. Classification of tendon injury in the hand. Sorry, I'm a hand surgeon, so this is always going to happen. Jersey finger, it's distal to the FDS insertion. Okay, so an injury, and it's caused a jersey finger because of a classic. Put your finger in someone's jersey playing rugby, the finger gets ripped out. You can get a soft tissue jersey, or you can get a bony jersey. Zone 2, FDS and zone palmar crease. That zone you can do a direct repair. Go back to zone 1, I think it's zone 1, isn't it? Yeah, zone 1. If there's a bony avulsion, how far will a tendon go?
Go as far as the nearest pulley.
Yeah, exactly. So it's not going to go very far, right? Now the good thing about that is all the vinculi will still be attached, so the blood supply is maintained. So actually, if you see an X-ray with a bony avulsion of the tendon, then you can relax and breathe and do it in the next trauma list available, which is here next 2 or 3 weeks, right? But if there's a flexor FDP injury and there's no bony avulsion, and you've got a scan that shows it's in zone 1, you need an early repair. Because it's usually pulled all the way back, usually to level of A1, A2, so the short and long vinculi blood supply has been disrupted, so it's not getting any blood supply anymore. That's all for bullets. But the point there is the zone 1s you need to be wary of. The rest you can repair at your leisure, but obviously the longer you leave it, the harder it gets. Zone 2 injuries as well, again, zone 2, so zone 2 injuries are always soft tissue, there's no bony avulsion, so they need to be repaired pretty quickly because they get avulsed back. Everything else, apart from the soft tissue zone 1 ones, they can be repaired for 2 to 3 weeks. My go-to incision in the finger, and I don't know whether it's just because of me, or I don't like it, but I always do Brunner's and they always seem to heal very well under my care, so I don't do the longitudinal incision with Z-plasty. My Brunner's seem to do very well, so I've got no reason to change. Okay, so this is your non-controversial exam answer, and then I'll go into some other bits and pieces which, if you're feeling adventurous, at the end of your question you can bring up. Okay, but if someone asks you how do you repair your tendon injury, particularly in the hand, right? Then you do Kessler 4-strand using a 3 or 4 row monofilament. And then you can talk about the balance between the number of suture strands and the number of buried knots. So we know that 4 is better than 2-strand repair, but we also know 6-strand is better than a 4-strand. But a 6-strand will give you 3 knots, whereas a 4-strand will only give you 2 knots. So the good thing about 2 knots is that you can just make sure both knots are on the opposite side of the tendon and you bury the knots within your repair. Okay? So that they're nice and hidden, so it's gliding. 3 knots, you've got to put a 3rd knot somewhere else. So usually that's round the back, so you're going to get adhesions of scar tissue to the periosteum, or at the front, where you're going to get catching and flicking of the pulleys, or scarring over the sheath, or you put 2 knots together, in which case you end up with bulk. So it's a balance. So 4 or 6 strands, 6 is better than 4, but 4 means less knots. Okay, and that's Tajima. Tajima's done loads of work into this, as well as Silver Skull and Anson. When you do a Kessler, I'll show you in a second, all your Kessler corners need to be locked, and your Kessler transverse anchor stitch needs to be 10 millimeters from the laceration, and dorsally placed if possible. Don't forget your little locked Silver Skull and Anderson circumferential stitch, which gives you 20% of tensile strength. So that's your primary Kessler at the top. So each corner locked, so it goes back in on itself. And then can you see it's staggered? So it's like that, and like that. Okay. So you're getting, in effect, 4 transverse sutures by doing a 4-strand repair. Okay. First is described in Kirchberg, not by Kirchberg, 1917. We should probably be rereading all the original articles, right? Because we seem to be going back to a lot of them now. This is your Silver Skull Lanson. So a lot of the time I see people just doing round-to-round sutures. Okay, that's not a circumferential stitch. You can see each corner is locked. Yeah, do you understand? It's not just a continuous circumferential stitch. It's actually each part needs to be locked. You choose. These are all the different types of suture repairs that have been described. They all claim to do better than the one previously designed by Mr. Stockmeyer. Stay non-controversial, just say Kessler. Okay. Other aspects, make sure you repair, if you put too much tension, the repair bundles up, and then it's never going to pass through any pulley or sheath, right? So make sure it's not bunched up, the tendon is still aligned, it's just neatly opposing. If you put it tight, it'll bunch up. Preserve A2 and A4. Now interestingly, I wrote some of this for a presentation I gave about a year ago, where it's a pretty standard technique was to vent your A2 pulley to allow glide. An article came out in Journal of Hand Surgery last month, saying actually that's probably not a good thing. So you should try, if you can, avoid venting your pulleys, but if you're struggling to get passage of your tendon repair through a pulley, then it's probably best to vent it. Remember, it's weakest on day 6. For 12, and it's relying on sutures alone. Healing we've spoken about. Healing, there's lots of rehabilitation, lots of different protocols to design. They're pretty standard answer, the pretty standard protocols which most people adhere to are going to be the Duran or the Kleinert, and both of them are low force, low excursion. So that's, so you're basically blocking certain movements. All right, and it's mostly passive movements to start off with. Okay, and they quickly move on to either dynamic or patient assisted. You've all seen those splints with pulleys and elastic bands on and stuff like that. Well, they're pretty good, they work. They're not hugely patient compliant dependent because they're actually doing the work for you. However, they're expensive. They take over an hour to fix to a patient, and the patient does need to take care of it, clean the hand, all that sort of stuff. So if you've got a really good hand therapy unit, you can keep on top of the patient, then it's fine. This just to show that huge Cochrane review has looked at this. There isn't one that's clearly better than the other. However, I will point you towards the Manchester protocols. Now, again, that's because I was CY's fellow, and so you kind of absorb everything that your mentor, your fellowships has done. And this is a really just a simple protocol, which presumably even the people of Manchester can follow. Right? And the splint is really simple, it's removable, it holds the wrist into extension and the metacarpal slightly flexed, and it blocks certain movements. It keeps the fingers open so you can do passive and active exercises, and because it's a Velcro strap, the patient or the hand therapist can change the diameter of it when the swelling changes, right? So you don't have to do a new splint every time, which some of the kind of complex stuff that you have to. The complications is comparative, but they've also demonstrated that the better arc range of movement is achieved with the Manchester protocol than the others. However, having said all that, this is fundamentally the huge meta-analysis, systematic review that basically is a summary of the Cochrane database review. And if you read all that, and in effect, it's telling you do what the hell you want. As long as you do it well, do it properly, you don't take shortcuts, and you have a very good hand therapy. Okay, so do what you want. However, be non-controversial. All Kessler stand. Tendons. We're running quite late. Any questions? And let's do nerves, but I'll be quick. I'll be 15 minutes.
Just on that last point, David Nairn, who's a famous hand surgeon in the region, president of the Hand Society and stuff, I worked for him, and he used to always say, an average hand surgeon with a great hand therapist will always be a great hand surgeon with no hand therapist.
Totally. Absolutely.
And you know, he was sad when he said that, because every time you had to make a business case for a hand therapy service,
Yeah.
it was such a rigmarole, when actually everyone knew that you could do not as perfect a job as a really brilliant hand surgeon, still get phenomenal results if you had a good hand therapy service.
Yeah. I totally support that, and we're very lucky here.
Yeah.
We're really lucky here.
Well, we weren't always, right? But
Oh, really?
the plastics guys did a lot of work. I remember
Yeah.
he was struggling at times.
So every Monday lunchtime, I do clinic all day Mondays, partly to escape, so I've got to do it clinic next to Alex. I go and have lunch with the hand therapists every Monday, and they properly look after my patients. So if anyone's interested in hand surgery, it's really important that when you go start snooping around jobs, you ask them about the hand therapy department. Okay. And if it's a small DGH and they haven't got a hand therapist, I'm not saying don't take the job, but know that you've got some work to do when you get there. Because you need a hand therapist. I pay for lunch, pizza, right? But this proves it all. It doesn't matter what operation you do, as long as you're safe and you're reasonable, the outcome is going to be the same. The difference is going to be the hand therapy. Yeah. Alright, let's do nerves. Has everyone got their bits of paper again? And I've got a bit of an audience, so we can have more of a quiz.
Seth can do mine. Seth do
Okay. Seth's going to do more.
Paul will do yours. Alex is here. Lots of answers.
Sam,
Oh, yeah. Oh, no, you can do one.
I did say to him, wait till I fucking meet her. I'm going to come out and get you all stuff out.
You've got a pen now?
I still have a pen, so it's okay.
No, I'm testing your...
Claire, of all the people here who
Did you get one yet?
you weren't here for the tendon throughout proteoglycans. Yeah. Where's all the consultant buddy protection gone? I asked myself.
Yeah.
It's gone. It's just the military. I'm in the military.
Okay. Oh, no. You can see that. Oh, okay, right. So first thing I want you all to draw is a basic peripheral nerve system neuron.
Oh, you haven't got a piece of paper?
Oh, yeah. It's alright, I've got the picture from Google. I'm paperless now. All these giving them away.
People are still drawing, so I'll hold off for a few seconds. Claire Fitzgerald's cheating. Okay, right. Most people are in pairs. Go on, swap them over. Okay, so it has to be a cell body, all right? A cell body with a nucleus, with dendrites coming out from the cell body, an axon, long axon. I said peripheral nervous system, so that has to be myelin sheaths with nodes of Ranvier, and there has to be a terminal, axon terminal with one or multiple synapses. Everyone get that? So you can mark each other and be rude.
10 out of 10.
Sorry? Out of 1. I have 0 or 1. Okay, so the next thing I want you to draw is the hierarchical structure of a peripheral nerve. So you guys missed on the hierarchical structure of a tendon. In tendon we have collagen on one end and tendon on the other end. Hierarchical structure of a nerve with your axon or cell at one end and your nerve at the other end. Everything in between. Again, this is one of those classic FRCS pictures. Right? Everyone they've had a stab. So, right at the bottom and the smallest, you have your axon or neuron with myelinated sheath. Okay. Surrounding that is an endoneurium. So hopefully everyone's got the endoneurium around their axon, primary axon. Okay. Lots of axons or neurons are bundled together to make a fascicle, and each fascicle is surrounded by a perineurium. Okay, and then all the fascicles bundled together to create a nerve, which are surrounded by a epineurium. For bonus points, then you would have had the blood vessels running parallel within, and the vasa nervorum on the outside as well. For bonus point. Everyone got that right? So other components, the blood supply. Nerves have two types of blood supply. Have an extrinsic, so that's normally segmental. So all the way during the course of the peripheral limb, there's perpendicular blood vessels dropping down onto the epineurium and perineurium. Perineurium is and that's external, and that's the vasa nervorum. And then intrinsic, so the blood vessels here within the nerve, okay, and they go all the way down the length of the nerve. Okay. Cells, of course, there's always cells, with a supportive role. Generally speaking, in the nervous system, central or peripheral nervous system, these cells are called glial cells. Okay? But there are lots of different types of glial cells. What are the glial cells of the central nervous system called?
The astrocytes.
Astrocytes, yeah, astrocytes. Within the peripheral nervous system, they're generally called Schwann cells. Okay? They arise from neuroectoderm, and they're responsible for the myelination of the peripheral nervous system. Okay. Now, people think that the Schwann cells are just a cell which wraps itself in. It's like wraps itself around the nerve. Actually, they create a wrapping that goes around the cell multiple times. Okay, so it's not like the pictures. Right, in fact, the pictures look like it's some just like a balloon, but actually, if you look closer here, you can see it's wrapped like a blanket, going round and round and round. Okay. And in between each swan cell is the nodes of Ranvier, and they're the gaps. And they're really important. Okay, they've got loads and loads and loads and loads of sodium channels in these gaps, and they're responsible to help accelerate the nerve. Okay, it's called saltatory conduction. Okay, and without these, the nerve amplitude would just slowly diminish the further you go down. So it's like a spinning top, right? Every time it gets to a node of Ranvier, the impulse gets whipped along. Okay, there's a new impulse of to the synapse. I haven't gone into the detail, but you need for the exam, you need to know the actual potential. It starts off at 0, goes up to a maximum of minus 70 millivolts, and comes back down beyond, below the 0. And you also need to know which sodium channels open and close at which point to be able to create the actual potential. Axonal transport, so transport within the cell body, within the axon, really important, because how else do you get all your acetylcholine or neurotransmitters down the end? And they run a shuttle service. There's like a bus service. It goes back and forth between the cell body. What's a cell body? Prokaryote, where it produces all the neurotransmitters, and all neurotransmitters, go to work. They pay the bus conductor, and they get in the bus, and they get transported all the way back, all the way down to the synapse, and then they get released into the synapse to help send the impulse. And then the shuttle buses go back empty, go back up to the cell body, and then back down again. Okay. So the shuttle system is retro and anterograde. All the energy needed for this is ATP dependent. Okay, so it's oxygen dependent. Quite a small amount of oxygen, but it still needs oxygen. There's no anaerobic activity to create the energy for the transport. Therefore, clinically, that translates to the fact that nerves are really fragile to ischemia, pressure, or any type of injury. Okay, so next time they're dividing a nerve, or you put your retractor over the median nerve. Okay, when you're doing your distal radius fracture, just think about that. So if anyone's done a distal radius fracture with me, I always mobilise the fat pad, or if there's always a bit of fat underneath the tendons on the bone surface of the wrist, and mobilise it up and around the median nerve. Then I put my retractor and open it up, just so you give a bit of extra protection from those teeth. Okay. Equally, when I'm doing carpal tunnel, I always use mini Langerbachs. I don't use a small soft retainer, because the recurrent branch is always where the teeth of the retainer want to go, and even just a little bit of kink can damage the nerve and interrupt the ATP dependent transport system and shut the nerve down. Nerves are really fragile. Posterior interosseous nerve, the old joke in the P&I fellowship was, you just have to look at the PIN and it switches off. Lots of fun. But the PIN has actually got a different protein sheet to it compared to any other nerve. So actually, although it's a running joke, posterior interosseous nerve is actually more fragile than any other nerve. So it's not, the PIN is one of those nerves that you shouldn't go and look for. Sometimes you look for nerves because you know not to, so you know where it is. So an example of that is superficial branch of the radial nerve, right? I always make sure I can see them. But when you're in the elbow and you think, I just want to know where the PIN is, okay, before I get my screw, don't. Just trust your anatomy, know where it is, retract it by all means, but don't start looking for it. Okay. Nerve injuries, there's etiological injuries, and the mechanism injury, just kind of list them out there. Physical, inflammatory, infection, ischemia, pharmacological, tumour, systemic disease, and iatrogenic. I haven't got a huge P&I job here, but I do, I don't know, I see a handful every clinic, and I'd say 50% of my nerve injuries I see in my clinic are referrals from iatrogenic. Superficial branch of the radial nerve is probably the commonest nerve I operate on for iatrogenic injuries. KY fixation of the wrist, styloid screw, or trapeziectomies where people haven't appreciated with a superficial branch of radial nerve. Mechanism, pretty standard, open, closed, acute or chronic, single or continuous trauma, whole or part of nerve depth lesion, and nerve state, healthy disease. You might have heard people call past nerve injuries degenerative or non-degenerative. That's different to what you probably think of as degenerative. So you think of degenerative as old, okay? Degenerative rotator cuff or degenerative meniscus. This is degenerative as in, has the axon degenerated? Has there been total nerve trauma to result in axonal degeneration or Wallerian degeneration? And whether there has been degenerative changes or not has a huge impact on your outcome. So non-degenerative, so true neuropraxia will recover within days. Okay, so the Tendon classification, but I still think the Tendon classification is the one which is, I don't know, just more clinically appropriate. I would, however, break neuropraxia, which is your Sunderland 1, your neuropraxia, down to 2, and that was described by Bircher. He described the neuropraxia into degenerative and non-degenerative, and he claims that you should probably never see a non-degenerative neuropraxia because you can't pick it up clinically. There's no Tendon sign. The neurology is almost so temporary that you're not even sure if it ever happened. Whereas the non-degenerative neuropraxia, where there has been a conduction block, however everything is still intact, they will recover very quickly, days to weeks. You then move on to the axonomatesis, where although the axon is in continuity, the nerves, while the epineuron, perineum is still intact, there's been damage to the axon itself, and that's the stage where you get Wallerian degeneration, everything distal to that injury. And for that to recover, the whole nerve needs to recover. So classically, you tell the patient 1 millimetre a day, right? And I'll give my tuppence worth about how we manage these in clinic in a second. Then neuropaesis is, okay? So neuropraxia, you leave alone. Axonomatesis, you need to follow up and make sure they progress. And then in neuropaesis, you need to probably repair. Generally speaking, I think it was Sue McKinnon. I don't know if anyone knows of Sue McKinnon. She's a peripheral nerve specialist. I think she's American, and she's written some amazing publications looking at nerve injuries. I think that her most famous and very controversial is the scratch collapse test. Has anyone heard of the scratch collapse test? Have you heard about it? No? Next time someone does clinic week, come and find me when anyone's got any nerve problem whatsoever, and I'll demonstrate the scratch collapse test. And that involves of the upper limb. Actually, I've seen CY do lower limb scratch collapse test of the upper limb, which is pretty amazing. Anyway, so if there's a nerve injury, be it cubital tunnel, carpal tunnel, neuropraxia, neuroma, whatever, you basically scratch over. Has anyone got carpal tunnel here? No? you scratch over the nerve, and you ask them to hold their arm like this, and then you resist their you ask them to resist your internal rotation of shoulder. And a nerve injury, a true nerve injury, will result in weakness in external rotation. Trust me, it's proper juju medicine. Right? We don't know why, but try it. Next time in clinic, come and find me, we'll do it together. We extended it further in Wrighton to the waft test, where you don't even have to scratch the injured nerve, you just waft the skin overlying it, and they have weakness in external rotation. Yeah, so Sue McKinnon presented this work at the AOS, and she was almost booed off stage, because it was just so out there. But she's done lots of really amazing work, particularly on how to treat neuromas, neurectomies, all that sort of stuff. But there is some strange stuff out there when it comes to nerve injuries. Factors determining prognosis, violence of injuries, polytrauma, delay between injury and repair, age, whether there's a gap in the injury, level of injury, so as in the arm, don't know why I put 18 months there. Oh yeah, so level of injury, the higher the injury, less likely it's to recover. If there's a very high injury and they have continued to progress and continue to progress, after 18 months, you're not going to see any significant further regeneration. Okay, a nerve regeneration, axonal regeneration, seems to run out of steam at about 18 months. It just kind of give that. Condition of the nerve ends, so tatty nerve ends, and polytrauma speaking about. This is my tuppence worth. All those things we discussed. Personally, I think 3 things which make the biggest impact to whether you get a good outcome following a nerve injury is the delay between the injury and repair. The literature says 3 months. The biggest and most recent article says 3 months. I still think anything over 2 days, and you're going to get a rapid. Okay, I'm not saying that at day 3 you might, oh no, forget it, don't repair it. But I think there's a rapid deterioration, and maybe at 3 months you just get bottoming out. But the sooner you repair a nerve, the better. Age. Okay, anything over 20 years old, and again you're fighting physiology. And the level of injury, we've spoken about 18 months. Okay, if it's left more than 18 months, or there's no further regeneration after 18 months, you'd have to have a really good reason to do a nerve surgery apart from neurectomy. I told you about the neuropraxia and axonomatesis. You need to watch them with Tinel's test. Okay, so you need to know your anatomy, particularly the radial nerve is very prone to injury. We've always spoken about it, so you need to know which one comes back and when and sensation. But you also need to record Tinel's test. Okay, so you follow the radial nerve through its course, and you every time you see them in clinic, you measure where their Tinel's sign is, and you find a landmark which you know that everyone else can find. So characteristically, radial styloid, ulnar styloid, medial or lateral epicondyle, and you measure where the Tinel's test is. The Tinel's test is 7 centimeters proximal to the lateral epicondyle. There's no point seeing them much sooner than 3 months later when you're watching for a nerve recovery. Then you measure Tinel's test again. If it hasn't significantly moved, so 9 centimeters, so it should have got further down the arm by 3 months, then it's halted. And if it's early on in treatment, the first 6 to 9 months, then consider neurolysis. Because nerves don't like going around corners. Okay, so when it comes through an intermuscular septum, when the ulnar nerve goes behind the medial epicondyle, when the median nerve regenerates through the carpal tunnel, or the superficial branch of the radial nerve comes around the radius, they don't like going around tunnels when they're regenerating. So if the Tinel's test isn't progressing from a known tunnel, entry or exit, includes all the fascial compartments and arcades of Froese and all those sorts of stuff, if it isn't progressing past those areas, then you need to go in relatively early, because you've only got 18 months, okay, to get that nerve past its sticking point. Understand? This is reconstruct the ladder of surgery or nerve, and this is mine. Okay, this isn't from a textbook, so there are some loopholes and gaps and caveats attached to it. So first of all, watch and wait. That's for your new practice, right? But and your axonomatesis. You need to watch and wait, but you need to actually watch them. Okay, you can't just neglect it and see them 18 months later. Neurolysis. So if your progression is halting for one reason or another, and it's normally because it's going from one part to another, then you need to think about a neurolysis. Repair, if obviously there's a direct trauma, or when you're doing the neurolysis, you see there's actually been an injury. Then you start cranking up nerve grafts and nerve transfers. Nerve transfers is moving a proximal nerve more distally, so that you already have a uninjured scaffolding bolted onto your clean cut where you've dissected nerve out. And finally, neurectomy. Neurectomy is your kind of last chance saloon. They've got painful neurological symptoms. Ideally, the nerve has gone past all its motor branches, so they're not going to be functionally impaired. So you're only losing sensation when you do neurectomy, but intractable pain from a known nerve injury or neuroma, neurectomy works really well. There are a couple of principles you need to apply when doing a neurectomy. And again, there's lots of literature out there and almost no evidence. That's all you know as a nerve surgeon is your own practice. So I would always use a clean blade, no, wrong. Infiltrate the nerve at the level that you're going to neurectomy, which should be proximal to the neuroma. Pre-inject it with a long-lasting anaesthetic, so I use a 0.5 marking. Wait at least 10 minutes so the local anaesthetic works. So if you know you're going to do a neurectomy as part of the procedure, inject the nerve first, do the rest of the procedure, then go back to the nerve. Under tension and on a clip, cut the nerve at the level of your injection with a clean blade, and then squeeze the end of the cut, and then with that clip, we're holding the nerve squeeze past the nerve to a compartment other than the compartment which it's supplying. Okay, so example would be superficial branch of the radial nerve, normally always here, okay, with neuromas. Inject it, cut it, squeeze the end, and pass it bonally, maybe under PQ or into PQ, and leave it in there. Do you understand? Okay, so you've got to move it away from where it normally supplies. Otherwise you get this overlapping symptoms, which is a disaster, chronic pain and all that. And finally, principles of nerve repair. Again, these are kind of classic exam answers. So you've seen the nerve, it's there in front of you, you washed your field, you've got a bit of green background underneath the nerves, and you're ready to go. What do you do now? Well, first thing you do is prepare the nerve. So you've got to trim the nerves. Now this is where it gets a bit angsty, because you've got to trim them, because literally within day 1 or day 2 of a complete transection of the nerve, you start getting Wendlerian degeneration, and on one end, but also on the proximal end, you'll see sprouting within 1 or 2 days. Okay, and that's literally, looks like lots of these little mushrooms coming out from the end. You've got to clear those out. You've got to trim those down. Okay, so a clean blade, nice sharp dissection. You've got to cut them until you see normal ends, because they're regenerating, but without all the signals from the epineuron to keep things going in the right direction. Next thing you need to do is approximate, and there needs to be a tension-free approximation. And loads of literature that supported this. Fundamentally, if it's at the level of a joint, the temptation is to flex the joint, then oppose the ends. But then, what do you do when you finish up? Put it straight again. So you're putting it. So you've got to make sure with the hand in a physiological position that the two ends come together. Now you can just like anything else, like a soft tissue closes, you can actually dissect the nerve out from some of its fibrous attachments to give it some ability to bring it back together again. But if you're finding that sutures are tensioning it, then you need to think really carefully about whether you should be doing a graft. Go-to graft for a peripheral nerve in my neck of the woods. Anyone know?
Distal PIN? Distal part of the PIN.
Yeah. So costointerosseous nerve. It's a really sizable graft. Okay, and you can match it up to pretty much mid forearm below. Admittedly, in the forearm you probably need to do a cable. So as many as you can to match the diameter, but you can easily get a good sort of 8 centimeters worth of PIN here. It's a really nice graft. Alignment, you've got to make sure everything's lined up. It can't be pointing in the wrong direction. So they just work because you are asking the nerve to regenerate like a train going down the axonal sheaths, the distal stuff. Repair it with a 9 or a 10-0 non-resorbable suture, and you do an epineural pair. Now the general kind of feeling is, if with your naked eye, or certainly with an orthopedic loose, which are 2, 2.5, you can tell the difference between the different type of fascicles, so motor or sensory, then you should probably do an individual fascicle repair. If you can't tell the difference, so you're getting sort of palm or fingers, then you just do epineural repair. Okay. So with orthopedic loops, I can tell the difference in the carpal tunnel between the motor and sensory. Okay, so I would do 2 internal fascicle repairs followed by an epineural repair. But if you can't tell the difference, be it because it's superficial from PIN higher up, then just do epineural. And that is it.
If I see a patient in clinic, let's say with a nerve injury,
Yeah.
shortly after, let's say, a knee replacement, for example, usually we assume there's a neuropraxia because you don't open up the.
How soon after?
Let's say a week.
Okay. Yeah.
Now, how usually we assume, but if let's say you have a complex procedure, and you want to be sure it's a neuropraxia and not a neuropathy. Okay, how do you go about making that diagnosis? Because it does affect
Yeah.
the outcome if it needs repair.
Yeah. Okay. So if it's so the key component here, I would say, is a Tinel's test and the sensation. Okay. If you're asking what their sensation is in the distribution of the nerve that's been injured, and they say that's a 7 or 8 out of 10, fine. You can go to sleep. Don't worry about it. Okay. Or if they've got a Tinel's test, then I think you're on safe-ish ground if they've got some intact sensation. When I mean 8 out of 10. If they've got 0 out of 10 and a negative Tinel's, you need to go back.
To explore the more.
Yeah. If they've got 3 or 4 out of 10, I'll tell you why these figures in a second, then you're in a difficult situation. And that is the point where you need to know as a surgeon whether you injured the nerve or not. And it's difficult if you're not the one who's done the operation. But if you've done the operation and you know your protective procedures, protecting the sciatic nerve, and the patient's come back with a 3 or 4 out of 10 neurology with a Tendon sign, and you're sure you saw the nerve at the end and it's fine, I think you're on safe ground. If you didn't look at the nerve, this is my Tuppence work. If you didn't see the nerve, or someone else did the operation, and they've come back with neurology, then there's an argument there to go in and explore.
If it's 0 or 3 to
If
4?
it's 0 or 3 out of 4 sensation, and you don't know if you saw that nerve at the end of the operation,
Wow.
yeah.
Because I don't know about pretty more, but I feel a couple of cases where it was maybe a valgus knee, quite a maybe slightly more complex than usual. Post-operatively had a neuropraxia, no sensation. Once I was operating, I knew that I wasn't near the nerve, and
Yeah.
because of the retractor probably, and I assumed that it was a neuropraxia. And then after he came back, I took quite. I was confident. I was thinking, shall I had the nerve conduction studies? It took a few months to come back.
Yeah.
But at the time, I was thinking, what if?
Yeah. So if this is a retractor problem, then I think you'd be within your.
So
You'd be safe to leave be.
I don't think.
But if it's in a zone of dissection and the differential diagnosis is an injury to the nerve, so direct injury, be it a cut, laceration, then I think
So I don't think at the point in time I was concerned about neurolysis. I'm more concerned about exolysis.
Yeah.
And whether it's 2, 3, or 4, whether it's a crush injury or not, which could be because some of the retractors are quite vicious. They're quite sharp as well.
Yeah.
So if I have a crush injury that may cause scarring, etc., of course the nerve connection may tell me that.
Yeah. So however, if there's no if you're not getting progression of the symptoms at 3 months, I'd have a low threshold to explore at that stage. I'd get nerve conduction tests. There's no point getting done much before 12 weeks, 3 months. But at least at 3 months, you'll see fibrillations or vacillations, right? If you're getting not vacillations,
Yes.
yeah, if you're getting
Paresthesia.
disorganized waves, not fibrillations at 3 months, you're fine. If you're getting fibrillations, then that shows a dysfunctional nerve. But again, if you're the surgeon, you know what you've done during the operation, so you're able to explain that. The other common one is sciatic nerve following total hip.
Is this perineal nerve?
Yeah.
Is there not, because that's often a FRCS question as well, right? Is it not just the deformity correction that's caused with your valgus knees that's contributing to it?
With fixed valgus for sure.
Yeah.
For sure.
Right. And so I counsel the patient beforehand. If they wake up with one, then I've done the surgery. But I sit tight, right? I give them a foot drop splint, I sit tight. Very different. So, unfortunately, you see, the funny thing is in a lot of upper limb surgery, you are going very close to nerves, right? By definition, in hip and knee surgery, we are avoiding nerves in pretty much all our approaches. And really, the only scenario, hip arthroscopy is slightly different, but in the posterior approach, getting the sciatic nerve in your closure with a suture is probably the only thing where I'm thinking primary injury. Right?
Or hematoma.
Yeah, so
I've seen a
hematomas
few
tend to
hematomas.
be incomplete pictures.
Yeah.
When you get a complete picture, right, I'm thinking someone's put a suture through, unless it's one of those high dislocations that we're stretching out. And again, a bit like the valgus knee sen, you kind of counsel to the patient, it's a crow 4, you're trying to bring it back down, you're going to be stretching tissue if they've had previous surgery. So it's funny, I think the principles are the same, but I think for a hip and a knee surgeon, they've got a lot more grip on how close they went to a nerve and how likely they are to have cut it versus a radial nerve in a humeral fracture, expiration.
That's why I said if it's your case,
Yeah.
then I know I'm safe, and you can reassure the patient. But if it's not your case, then
For sure, and that's why it's very reassuring for us to hear you teaching, because Normally we get Mike Fox or Rolf Birch or somebody like Thomas Caster. They've all been in this room and taught us, right? And when they teach us, they have a very one-dimensional view because it's never their case.
Yeah.
And you know, you talked about your rate of iatrogenic injury. Rolf sees 100%.
Yeah,
right?
that's his job.
When he was working, were
Yeah.
iatrogenic injury. So he would stand there and say you should never cross haywire a supracondylar fracture because every case I've seen has a nerve injury, right? And Mike Fox finds it very hard when, you know, I have a to and fro with him saying, come on Mike, you're only seeing those cases. And occasionally in the morning trauma meeting we get an element of that from Alex and Nima on their complex infection cases, right? It's kind of what you get if you do a really complex tertiary service for stuff that other people, it's beyond their area of expertise. But you've always got to just keep that kind of grip on the fact that everything you see is a complication, but not all cases get to there, right?
Yeah. So the scoring system, as scores I mentioned, actually there's evidence behind the fact that when you ask a patient to mark out their sensation out of 10, they'll give you the same number every time. 0, 3 or 4, 7 or 8, or 10. They won't give any other number in between. And they all
Which sensation is better, the vibration or 2-point discrimination? What's the sensation?
Yeah, but then all those things are specific, different. You're not going to be able to tell when you do a nerve neurolysis or repair which is an afferent, which is an alpha nerve and a B1 nerve and a C nerve. Which are all the different 2-point discriminator. So I think you just need to keep it. If you're doing the fingers, if you've got a P&I service and you're looking at recovering the fingers, then 2-point discrimination is really important because the sensation is quite gross in the fingers. But I think everywhere else you're talking about, peripheral nerve areas. Tips of the fingers, 2-point discrimination and vibration are really important when you're doing nerve transfers or hand transplants. Anywhere else, maybe Nima might do 2-point discrimination for diabetics.
What are your thoughts on blocks? Because I know, for instance, like you have a distal humeral fracture, a lot of orthopods will say, let's not get a block, I want to assess the nerves thereafter. I spoke to one of the anaesthetic coaches and they were saying they actually have guidance to suggest that they should still do a block because at the end of the day, if you identify anything post-operative, what are you going to do for it?
So, you're always talking to the wrong person, only because I do a lot of my own blocks. So, and I know it doesn't take me an hour and a half.
Especially if you can visualise the
Sure,
nerves,
absolutely. I know the anaesthetic guidelines and all that sort of stuff, but my first ever trauma list here was on a Friday, 7 days after I started. I did a humeral fracture and it took me about 3 hours because I was always this complex, it was 4 weeks old, all that sort of stuff. And one thing I wanted to do was check the radial nerve at 6 o'clock on a Friday before I went home. 11 o'clock that night, the block was still in situ. So I came in Saturday morning. So I kind of wasted my weekend just because I wasn't bold enough to turn around to Denise and say, we not do a block and I'll do a block at the end.
I mean, they do this with compartment syndrome. We had that conversation this morning, so
Yeah.
they look at the acute episode, not the ongoing care, because that is anaesthetics, right?
Yes, yeah.
It literally is they put them to sleep, they wake them up, and it's your problem. The surveillance and care of the patient all comes down to us.
Yeah.
So they'll say, it's compartment syndrome, even if we've given a block, a breakthrough pain. But who's going to keep checking at what point the pain is breaking through, keep looking at them clinically? That's us, right?
Yeah.
And that's why you tell them to piss off. If you're genuinely clinically worried, you tell them to piss off.
I think if you're doing an example is a Holstein-Lewis or a mid-shaft humeral fracture, where radial nerve injury is not just a recognised complication, but actually one you actively try to avoid then I think you need to have that discussion with the anaesthetist saying, actually on this occasion I don't want to block because I want to see the radial nerve working straight away afterwards. But you know, distal humerus orif, where you transpose on the nerve anyway and it's out of sight, then fine, block away. Mid forearm, block away, all these sort of things. But I think something like Holstein-Lewis, where you're directly mobilising the radial nerve and specifically want to make sure that your plate hasn't been squashing the bejesus out of the radial nerve at the end of the operation. I don't block. I don't know what you guys.
Yeah, I must say I would probably block them because
Yeah.
I can see the nerve, I can see that the plate's not there.
Yeah.
But
I mean, that probably there speaks an extra couple of years of consultanthood above me, but yeah. I'm still twitchy as hell. Yeah.
So let me clarify.
Maybe I'm more twitchy. Yeah.
Are you telling me that less than 3 months, okay, if you have a nerve injury, there's no investigation apart from clinical examination?
There's no point getting nerve conduction tests, and some would even say 3 months is too early. But you're not going to see improvement in. You're not going to see a normal nerve conduction test no matter what at 3 months, but you will see fibrillations or fasciculations. And fibrillations means the nerve is still two ends of the room, opposite ends of the room. Yeah, it's difficult. It's really difficult. But that's why you saw what I've said. What you've got to watch. It's not. What's the phrase? Clinical neglect. No.
Watchful neglect.
Skillful neglect. You've actually got to see them regularly every 3 months. Because if you don't see progression, you've got to go in early because you've only got a certain amount of time before the nerve packs up its bags and goes to the morning. You're worried.
Yeah, of course, because
Yeah. We all should be worried.
I do the career set
That's my job.
osteotomies around the pelvis, and I got a sciatic nerve, femoral nerve, and the lateral femoral cutaneous nerve for the thigh. For the sciatic nerve, sometimes usually 1 or 2 days they come back very quickly. If you have a neuropractor, you can bruise it a little bit. The femoral nerve, if I push it aside to cut the superior pubic awareness, sometimes it take a week or 2, but they show progression, so that's okay.
Yeah.
Now, the thing I don't understand is the lateral femoral cutaneous nerve of the thigh. I visualize it, I protect it. Put it
It's
on
got, if you anywhere near it, even if there's a bit of saline dropped on it, that's the biggest fucker ever knows. You talk about the PIN, lateral cutaneous nerve of the thigh. Eesh.
With that I was trying to protect it. I put it aside. I usually stretch it because it's right in front of my approach. The thing is that sometimes it recovers within a few weeks, sometimes a few months, and sometimes it never recovers. I cannot tell. Okay?
Okay. Well, do you do Tinel sign?
No.
If in 3 months' time you've still got a Tinel sign at the site of the lateral cutaneous nerve of the thigh, at the level of the inguinal ligament, it means it hasn't progressed and there's scar tissue and it's not moving out. Okay. If the Tinel sign is distal to the inguinal ligament, 3 months down the line, then it's recovery. In which case you say yes, you've still got paresthesia or hypoesthesia or allodynia, but there's signs of nerve degeneration all the time. But if you're seeing them at 3 months and they've got Tinel signs over the inguinal ligament, see them at 6 months, they've got Tinel signs in the ligament, see them at 9 months, they've still got Tinel signs in the ligament, then you're missing the boat.
My reason for the lateral femoral cutaneous nerve is just academic because I tell them usually it's sacrificed.
Yeah.
A lot of my mentors, they just sacrifice it. Even Sabah would say that he tell patients that it will be sacrificed, but he try to keep it, and some they come back.
Yeah.
And even if there's a small non-patch, we will go and explore and try to make it a big thing because the patient is happy. It's just a cutaneous distribution. But what but the issue is that I cannot tell when I close the wound whether this nerve will recover or not.
Which category you're going to fall into?
Precisely.
Yeah,
I
but I
cannot.
mean that's so there is an element in these stretcher, these very sensitive nerves of ischemic injury, I think, is what people are saying, because the trauma you're applying doesn't seem to fit with kind of your classic sedent injury. We don't know about that. The final thing I would say, again, this is mainly for the registrars based on what Taff has just said. He is absolutely right about the value of a nerve conduction study in terms of you interpreting a nerve injury and then acting on it. But in my experience, there is a separate episode which is you and a patient who's got some kind of nerve consequence after your intervention, and sometimes you do send them for a nerve conduction study earlier just to manage the patient, but you're not really looking to interpret the results at all. And I've certainly done that, knowing that, because patients find it very, very frustrating if they've got something like a foot drop and then you do nothing, you just say kind of, let's sit tight. So if you send them, you say, look, this is going to recover, but you send them away for a test, you're not going to act on the test because the information it gives you is almost, and sometimes you'll get a letter back and you can often just say, look, I want to get a baseline reading of how this nerve is functioning or whatever, but it really does help in managing the patient, even though it gives you, you're not going to get any information. I don't know if you found that,
No,
but
what
certainly
I do is,
I've done that on more than a single occasion.
what I do is I send them at about 6 to 8 weeks once. I know it's not going to do anything, not going to tell me much. And then if it doesn't recover as quickly, at 3 months, 4 months, I send them again. And sometimes you see whether there's a trend, whether there's a difference between the two nerve condition studies, although they can't really tell you definitively whether there's nerve, but if there's a difference and there's a trend, I'm hoping for that. So I don't know whether it's...
One thing I would say is if you're doing that, which I totally buy that, because you're managing the patient, make sure you're accurate on the nerve conduction, the request form, how many weeks it is. Because they will do different amplitudes and different tests according to,
based on when.
because if you're just a little bit economic with the truth and you tell them it's now 3-4 months following the injury and it's actually 2 months, they might begin to crank up the amplitude and they'll get false readings, and then you'll then get the wrong conclusion. And then you're in a difficult situation because he'll tell you, oh my God, this is
all gone.
You need to go in now. You need to go in because according to the results.
So can I ask about what I'm doing, whether it's bogus enough? Because it's like a CLP, right? If you measure a CLP, let's say immediately post-operatively, it's going to be high, right? But if you measure, let's say 3 days intervals, you can see the trend. It's still high, it's still abnormal, but it's going down, and that's really showing the trend. Does nerve conduction study follow a similar pattern like that?
No.
No.
So this is a long latent period where nothing happens before healing starts to happen.
It's not a. It's. I was about to say it's not a qualitative study. It is, but not in the same way as CRP. So during that time where it's not working, you're not going to see a change in the figures until it meets a point on the curve where it starts working. It's going to be all or nothing.
Just on the switch.
Yeah. The problem is if you tell someone that the injury is 4 months old and they get recorded fibrillations, they will tell you there's no recovery. You need to explore, repair, neuron stuff. So it's not a curve. Although once it begins to recover and muscles are reinnervated, you do then start to get a qualitative result. So the amplitude changes as it recovers, all that sort of stuff. And carpal tunnel nerve conduction test is qualitative as well. The bland classification tells you how severe and how they'll respond depending on response treatment. But no, if it's not working, they don't tell you, oh no, it's just 2 millivolts off working.
Well done. Thanks, Taff. Can I have my prize? I got the top score, I think, in the quiz.
Did you? Oh, yeah. You mean Mr. Google?
See my picture.
You missed out the test.
3 people.
More people. The registration.
Yeah.
Yeah.
would you
I did.
swap?
Oh yeah, no, right, yeah. So if there's a huge fight,
No, sorry. It's a totally separate process that we're being a bit bollocks by that.
yeah.
But actually Phil Johnson is taking it.
I've seen it.
You'll be fine once you're there. It's just that you
Is the guy who's coming here? Yeah, Jay.
Yeah, so, yeah. So they
He's by definition going to be
so
Can you finish Jay's consult job?
Yeah.
Just so you can bring the Neil technique. He said that was the point. So yeah, I thought he was going to Manchester.
He got a consultant job in Manchester. His wife didn't want to do it particularly. He said, look, this is a job, and then his wife found out that there was a job in Cambridge. And said to him, look, you've got to go for that job. And of course, Dow, do you know Dow?
No.
So Dow's a part of the programme. Dow is the fellow there who was hoping to get that job. He got a local job. So then Jay's wife said, if you don't...
Can I ask you for a September 20th? It's a Friday.
It's not on the inside. He was really kind to us. So he also then an hour to chat about this, and I was getting real good advice about him. Jay. Yeah. So that was really helpful.
cheers, man.
You alright?
Yeah, a bit disappointed. I had 2 hips tomorrow, well, my Thursday.
I don't know. I mean, it's crazy.
Don't get your ass last night. But yeah, any Friday.
How are you?
No. Oh yeah.
So what happened? It's out of the blue.
Malaria and TB in the lungs. So just you don't tell me.
Yeah.
But telling stories on the phone.
Yeah.